Good morning, everyone. Thank you for joining us this morning. My name is Camilo González Velázquez. I am an associate professor in endocrinology at the Universidad Autónoma de Nuevo León in Monterrey, Mexico, and co-host of this Thyroid by MD's webinar series. I sincerely hope that you're doing great and that you have a nice cup of coffee at hand to enjoy what is set to be an incredible presentation. Today, I'm honored to introduce Dr. Elizabeth Cottrill, who will be presenting us with a lecture on machine learning in thyroid nodule and thyroid cancer diagnosis. Dr. Cottrill is an associate professor in otolaryngology and co-director of the Thyroid and Parathyroid Centers at Thomas Jefferson University Hospitals in Philly. She's an author of many very thought-provoking publications focusing particularly in thyroid neoplasia. And we do want to encourage the audience to send questions through the Q&A function, and we will try to get to them by the end of the hour. So without any further ado, Dr. Cottrill, the mic's all yours.
Thank you so much, and thank you guys for inviting me today. It's really nice to be here, and I'm excited to share a couple of our studies with the group and maybe have some good discussion afterwards. So I am going to see if I can get my slides to advance. There we go. So again, I'm Dr. Elizabeth Cottrill. I'm coming to you from Philadelphia today. I'm at Thomas Jefferson University, where I'm an associate professor and a co-director of our Thyroid and Parathyroid Center. My talk today is going to be on machine learning in thyroid nodule diagnosis and cancer detection. So I have no financial conflicts of interest to disclose. And I will start with the kind of where we are in terms of figuring out where the problem lies. So this is the way that I think about the problem. Number one, thyroid nodules are common, super common. The prevalence of a palpable nodule, at least in the US, in women is about 5%, in men is about 1%. But we know that tons of nodules can be found incidentally, like on imaging that people get for other reasons. And if you were to use ultrasound on a population of adults, at least in the US, it's about 60% of them that you would find some kind of nodule in their thyroid. So knowing that, also knowing that only about 7 to 15% of these nodules end up being cancerous and therefore something that we need to be worried about from a clinical standpoint, we have this problem of overdiagnosis or indeterminate nodules, and trying to figure out, kind of be the detectives that we need to be to figure out which ones we actually need to care about. So this is just from the SEER database. It was estimated in 2021 that we would have about 44,000 cases of thyroid cancer diagnosed in the US, and that we would have about 2,200 deaths. That's the most updated information. If you were to visually outline the cancers that come from the thyroid, we have the epithelial or follicular cells. These are going to be the ones that generate thyroglobulin, as well as parafollicular or C cells, either neuroendocrine cells. They make calcitonin, CEA, and some other chemicals. So in terms of the follicular cells, we divide these into papillary follicular, Hürthl cell, which is a type of follicular potentially. And we see that these subsets of cancer generally will have a strong driver mutation. In those well-differentiated thyroid cancers, they're kind of profiled in a way. And we see that for medullary thyroid cancer, these are most often RET mutations. Poorly differentiated cancer can evolve from these. And then we also know that anaplastic thyroid cancer can also evolve from these. They tend to keep their same kind of driver mutation as the parent cell, but then devolve and sort of snowball into having more and more and more mutations. So we want to figure out which ones are that 7 to 15% that we need to care about. So in nodules that are detected by either palpation or imaging, we obviously begin with our history and physical. We do a TSH and looking for those that are suppressing the TSH. So if we have a suppressed TSH, we'll start with an uptake scan looking for a hot nodule or multiple hot nodules. And then if your TSH is normal or high, we begin with a diagnostic ultrasound. So that's kind of where I'm going to begin today, is thinking about this ultrasound. Detailed neck ultrasound, especially with concurrent evaluation of our lymph nodes, is standard of care for evaluating thyroid nodules. And surgical management is importantly altered in the presence of lateral neck lymph node metastases. So it's important that even for small nodules, we're looking for those. Ultrasound is just an awesome tool. I try and teach my residents as much as I possibly can to use it and to kind of use it as like the surgeon's stethoscope in a way, or looking underneath the skin. It's kind of our X-ray vision, to see what's there. And it can help us really to identify things that we didn't necessarily feel on our physical exam. So this is, for example, a 1.1 centimeter nodule in a young woman who didn't have a palpable nodule. I actually don't even know why she ended up getting an ultrasound with her, I think it was her gynecologist, but ended up finding a nodule that had some concerning features. So nodules can then be evaluated on this sort of scale, looking at various features that make them higher risk or lower risk. And so this is an excellent paper from the 2015 ATA guidelines that Susan Mendel outlined, just a wonderful pictorial view of sort of what makes those high risk and low risk features. If you then look at the two groups that have used these high-risk features or low-risk features to kind of make a stratification, one is the American Thyroid Association that we have used since at least 2015, and then the other one is going to be the American or the Radiologic Society, and I'll show you that in just a minute. Importantly, they're slightly different in terms of who they recommend or which nodules they recommend to be evaluated with a needle biopsy. So importantly, the ATA criteria for high and intermediate suspicion pattern nodules will recommend for greater than equal to a centimeter, whereas TI-RADS criteria, you can see for moderately suspicious, they don't recommend until greater than or equal to 1.5. So a slight difference there. There are other slight differences, and I'm not going to spend the time to go into those right now, but we have to remember that these criteria are simply criteria, right? They are discussing or trying to stratify these nodules based on the information that the radiologist has at hand, which is the images. The criteria don't take into consideration the history and physical. So we as thyroidologists are able to incorporate a little bit more of our clinical acumen to look at, nodules that say grew, for example, over the past year significantly, or looking at their physical exam, seeing that their laryngoscopy reveals that they have unilateral vocal fold paralysis. Even if they have a small nodule, if it's posteriorly located, it certainly can be very concerning, and honestly would be considered concerning until proven otherwise, really. So when we're looking at these nodules, there also may be inter-reader variability. This may be dependent upon experience level or years in practice, their ultrasound volume, the quality of their images, what kind of machine are they using. And then there's possibly even a higher risk of variability for indeterminate nodules. This is based on a study that our group did, actually kind of linked to the studies that I'll be talking about later today in the presentation. I put the reference there in case anybody wants to take a look at it, but we found that there was actually a higher inter-reader variability for indeterminate nodules. So exactly the ones that we're sort of trying to figure out where they belong, those were the ones that had the highest inter-reader variability. So even when there are strict criteria, we know that the ultrasound reads are subjective, and there may be that that error built in. So once we have our decision that yes, we are going to go for a needle biopsy, then we have another set of criteria and diagnostic hurdles to go through, and that's with cytology. So our 2017 Bethesda criteria, which is what's used in the United States, is outlined here. And as you can see, there are two columns now where there used to be one. And specifically, I try to look at this one. And this is if NIFT-P is not a cancer, what is our risk of malignancy? Obviously, they're both there for a reason. So it's important to kind of understand why this talk is not about that. But basically looking at these two indeterminate groups, atypia of undetermined significance or FLUS, and follicular neoplasm or suspicious for follicular neoplasm. So in these particular nodules, we know that there is an approximately anywhere from 6 to 40% risk of malignancy. And unfortunately, up to 30% of needle biopsies may be in this category, in one of these two categories. So it's very important to remember that this is kind of a big number of nodules that we're looking at. So with all the inherent uncertainty and subjectivity, the question is, where can we get a more objective answer? And my patients, I think, would love all of us if we could just tell them black and white, this is or it isn't. I think it would make all of our headaches go away, at least in thyroidology. So this is where, molecular testing has kind of tried to really bring us some concrete yeses and nos, and it hasn't really been able to do that in a lot of cases. There are some mutations that obviously we all know are definitively, high risk or cancerous, and that is very helpful. But there are a slew of other mutations that we see, including a lot of the RAS mutations that can be seen in both benign, say for example, NIFT-Ps, or malignant nodules. And so what we see here is, again, kind of a stratification. It helps, but it doesn't, again, give us that black and white. The bottom line is that they can help this risk stratification. There still continues to be overlap and uncertainty. So again, going back to defining our problem, again, thyroid nodules are common. Only 10 to 15% are cancerous. There's inherent uncertainty and inherent error in our clinical diagnosis standards as of today. And then because of this, what's the ramification? Patients are subjected to unnecessary surgery, and there's obviously inherent risks, financial toxicity, all sorts of other things that we would like to avoid if it's possible. So we go back to our clues, where can we find this information? How can we hone in on this? And there have been a lot of studies and different algorithms that have tried to come up with a way to sort of calculate this risk as closely as possible. But there still is this kind of spot in the middle where we don't know what to do with these nodules and how to counsel a patient regarding whether or not they should have some kind of a treatment for it. And so this is where I really, would like, I'm sure all of us would really like to eliminate this middle. This is where machine learning may or may not be able to come in to help us. So I'm going to begin with a couple of definitions. So artificial intelligence is a theory and the development of computer systems to perform tasks that normally require human intelligence, such as visual perception, speech recognition, decision-making, translation between languages. Machine learning is then the use and development of computer systems that are able to learn and adapt without following explicit instructions, by using algorithms, statistical models, et cetera, to analyze and to draw inferences from patterns and data. A lot of patterns, and that's what we're going to kind of focus on in just a minute. Deep learning then is a type of machine learning that's based on artificial neural networks in which multiple layers of processing are used to extract progressively higher level features from the data. So this is at least one person that I have kind of been interested in following regarding AI in medicine. You may be familiar with his book, Deep Medicine. This was a Nature Medicine review that he wrote, which is really quite a good read, and it's very interesting kind of on a broad scope to kind of think about AI in medicine and where it's going. Really, I think that in particular, there are advances that are going to happen, or that are happening really specifically for the clinician, but then also kind of for the medical system, and then also actually tools that are going to be at the patient's disposal. So there are kind of areas in which we have the ability to kind of hone in on these things. So the biggest thing I think for clinicians ourselves is predominantly this rapid and accurate image interpretation. So the way that Dr. Topol describes deep learning neural networks is that they consist of digitized inputs such as an image or speech, and these are processed through multiple layers of connected neurons. These are not neurons like we have in our brain, but these progressively detect features and ultimately provide an output. he describes this basic DNN architecture as a club sandwich. So I put one here. Actually, this is a hoagie for those of us Philadelphians. This is a more appropriate sandwich for us. So this is kind of how he describes all of these layers that are really truly hidden, a black box from the person who's inputting those images and then getting to see the output. So that is our hoagie. So machine learning can be used to basically take an image and teach what this image actually looks like, has the ability to classify these. This is a cat, or this is a dog, or this is a duck. It can also localize these, and that's one of the things that we have used in one of our studies to see if AI can actually locate a nodule within an overall ultrasound still image. And then it can also kind of begin to sort out different images. Once it's localized one, it can localize multiple and categorize those as well. So I love this this picture. We have the question, is this chocolate chip ice cream or is this a Dalmatian? And AI can maybe as well or better than us determine which is which. Oh, there was another one. I was supposed to have, there was another picture here that also had a sheepdog and a mop that were also great images to kind of squint your eyes at and really see if you could tell the difference between. So the question that I have and that our group had is, can automated machine learning be used in order to predict which nodules are going to be those that are clinically important for us? So in our study, we really wanted to hone in on those Bethesda 3, Bethesda 4 indeterminate nodules. And so we used a subset of nodules that specifically had next generation sequencing at our institution. The indeterminate nodules that we see kind of automatically or by protocol get next generation sequencing at our university. And so rather than focusing on Bethesda 3 and 4 nodules that went to surgery, we began to look at those that had NGS. The reason for that, even though NGS doesn't give us as definitive, a diagnosis, it allows us to not have quite the same amount of selection bias as if we were to look only at those that then went on to surgery. As you can imagine, Bethesda 3 and 4 nodules, many of them, if not the majority of them, don't go on to have surgery. And so when we look only at those that have final histopathology for us to identify, that there may be really a truly significant selection bias there. So we designed our study to evaluate the AI diagnostic accuracy in the setting of genetic risk stratification. So high risk mutations versus low risk, no mutations. This was specifically used on thyroid nodules on the B mode ultrasound, and we were using them also to evaluate the performance of the AI in locating the thyroid nodule, as I mentioned before, that localization, and then evaluating radiologist performance when using TIRADs with and without AI assistance in the thyroid nodule stratification, risk stratification. So our first study was a retrospective review. And we had IRB approval, obviously. We reviewed the electronic medical records of all adult patients who underwent ultrasound FNA of a nodule with subsequent molecular testing. So this is vast majority of these were going to be those indeterminate nodules. And this was from January 2017 to August of 2018. Patients were excluded if their medical records were not available or if we didn't have ultrasound images within about 6 months of their FNA. And we had about 134 nodules that underwent ultrasound imaging and either ultrasound guided FNA with next generation sequencing or who underwent surgical resection. So we had a final pathology diagnosis to evaluate them for high risk or low risk. And in our study, we had a radiologist. This person has more than 15 years of experience in thyroid ultrasound. He was blinded to the cytology, to the NGS, and also to the histopathology. And he selected diagnostic ultrasound images of each lesion, resulting in a total of 683 images. The radiologist then used bounding boxes and labels to mark the location of the nodule, as well as cropping out kind of the words, the name and the date and that sort of thing on the page so that it wouldn't kind of cause noise, I guess, in the algorithm. So they used the blinding boxes, and that was what helped prepare those for processing. So once that was done, I'm going to go back and say that at our institution, our next generation sequencing panel is very similar to ThyroSeq. At the time of this particular study, we had about 23 evidence-based gene mutations associated with thyroid malignancy that served as a reference to mark our FNA samples as either high risk or low risk. And in cases where surgical resection was performed following ultrasound imaging or with or without NGS, the final malignant or benign pathology was used to designate high or low risk. So then we used automated machine learning, and this was performed on a commercial platform. This is the AutoML Vision, which is a product of Google. This platform generates a custom model from processing the images for classification by transfer learning with neural architecture that's optimized on a proprietary basis. So kind of this big black box. The product specifications recommend between 100 and 500 images per classification label. So after images are submitted for processing, roughly 80% of these images are selected for training the model, and then roughly 10% are used for validation, and 10% are set aside for testing the accuracy of the model. So in our setting, we had a total of 134 unique thyroid nodules. Ultrasonography identified various images of those nodules. So we ended up being able to use 683 still images, and this was in a blinded fashion, again, to their NGS, their pathology, their cytology. And extracted images were then randomized into a training subset, which included 556 images, a validation subset, which included 74 images, and a testing subset, which only had 53 images in the end. So you can see how you feel like you have a huge amount of data, and it kind of gets whittled down because so much of it needs to be used for the training. And honestly, this is kind of bare minimum. So really, it would be even better if we had even more. But after training and validation, the model was tested on unique images. So these are all unique, not ones that they had seen before in the training or validation models. So, and then it was tested on its ability to correctly label these as high risk or low risk. So our population included patients that were generally kind of a median age of 55, significantly more female than male, as we know is common in our population for thyroid nodules. The lesion location, we decided to take a look at this in case it made a difference in terms of how well the AI stratified them, and it didn't. So approximately 40% were lower pole, 30% were mid pole, and then some of them actually took up the entire lobe or were in the isthmus. Few of them were in the upper pole. So, but it didn't seem to matter with the processing of the lesion. The size averaged about 2.65 centimeters, plus or minus 1.45. And the NGS status, so about 30% of them did have a high-risk mutation or fusion. About 11% had a mutation of unknown significance, the most common, and I think actually all of the ones in this particular study were TSHR mutations. And then 56% had no mutation or fusion, and therefore were low risk. So these were our results. Our model sensitivity was about 45%, but the specificity was 97%, which we were actually pretty surprised it was actually that good with a relatively small subset of data. So, sorry, I'm trying to catch up on my other slides. So in terms of, what we took away from this, we found that automated machine learning definitely shows promise in the development of a model based on ultrasound alone to predict lesions that are likely to be malignant. And again, this is kind of honing in on those nodules that had indeterminate cytopathology. We found that machine learning algorithms may provide a cost-effective and rapid point of care addition to the armamentarium of thyroidologists. So where do we go from here? We wanted to know, can we incorporate an AI algorithm with thyroid ultrasound, specifically with object detection to look at those nodules within a TIRAD scoring system to actually improve our own or radiologist's own prediction of genetic risk in these nodules. So we did a second study. And this one included 252 nodules from 249 patients. These are patients, again, who underwent ultrasound, who underwent needle biopsy, and who underwent next generation sequencing with or without resection. And again, a machine learning model, again, that AutoML Vision from Google was employed for an automated nodule identification and risk stratification. There were 201 nodules used in this study for the module training and 51 that were reserved for testing. So 3 blinded radiologists then scored the images, and sorry, I couldn't help 3 blind radiologists. They scored the images of the test and decided on the nodules being TIRAD scored based on their own, experience and that sort of thing. The average experience level of these 3 radiologists was about 11 years total, lowest being 5 years and highest being 15 years, over 15 years actually. So the presence of highly suspicious imaging features would be things like hypoechoic echogenicity, taller than wide, extrathyroidal extension, punctate echogenic foci, etc. And then subsequently, these were classified into high risk and low risk using 1 through 3 as low risk, but then incorporating the AI to modify that TIRADS 4 classification, TIRADS 5 being high risk. So this is kind of the model that we use, or a diagram of how we performed this study. And so using this AI algorithm alone, without the radiologist, it correctly identified all nodules in the test data set. So I had a 100% object detection, but it only showed a sensitivity of 73% and a specificity of 70%. So relatively low when used alone. The radiologist alone, unfortunately, had a sensitivity of 52% and specificity of 65%. But when you combine the two using the modified AI TIRADS method that we did, in other words, where the TIRADS 4 nodules were actually deferred to the AI algorithm, we actually saw a pretty significant increase. So a specificity that went up to 83%, which is not bad. So we found in this study that incorporation of AI into the TIRAD scoring system improved our radiologist performance and even showed a better prediction of high-risk genetic mutations than AI alone when classifying thyroid nodules. Again, this is specifically looking at those that are more in that indeterminate cytopathology. We concluded that employing this AI is a possibility and can be used in existing thyroid nodule classification systems to help us more accurately identify those high-risk nodules. So future directions, I think for us, we wanted to focus a little bit more on model optimization, performance, and then also validation. Just the more data we can feed in, the better. So these things that we also want to kind of hone in on are feature extraction to confirm the use of only anatomically relevant features, anatomic segmentation for increased lesion specificity, and then prospective validation. As my 18-month-old would say, the future is bright. And so I wanted to, this was actually just 3 studies that have either been published or presented only in the last 3 weeks. So you can just see that there's kind of an explosion of studies looking specifically at AI's use in radiology. So this is another one. This was just published February 22nd. And then this one was actually one I was super excited to get to hear at the very recent Multidisciplinary Head and Neck Cancer Symposium just 2 weeks ago. And this is a study that's out of Mass General. This was Annie Chan presented this. It was really, unfortunately, quite short, and I would have loved hearing a much longer talk, but was very, very exciting to see their success with it. So future directions is hopefully going from something like this and using it actually in things like cytology. So other places where there's pattern recognition. So it's not just about our radiology, but actually our cytology may be something where we can kind of focus in next. And I know that there are some groups that are looking to that. I think that, the ability to do some inter hospital collaborative studies is also going to be really helpful in this arena, where the bigger the data set, the better our output. So I want to say thank you very much to the THANC Foundation and to Dr. Brito for inviting me. I also want to say thank you very much to the Jefferson team. John Eisenbray is kind of the mind behind all of the AI. So hopefully I did an okay job of explaining it. I'm just a thyroid surgeon. So it is not my specific area of expertise. And then the rest of our research team. So without any further ado, I will take any questions.
So thank you, Dr. Cottrill, for this amazing lecture. I think it gave us a lot of homework and things to think about, and how to close that gap between what is white and what is black. And with that, in regards to that, while the rest of the audience sent in a couple of questions, I have a couple of my own that I've always thought about. So here I go. What is the basics that anyone would need to, you were speaking before that there's inter-observer variability based on the user, their experience, the machine that they use. What would you say is like the bare minimum that people need to attempt doing something like this, so we can start doing, for example, collaborative work between different hospitals? So, I mean, that could be technology-wise, I don't know, human resources. What do you need?
Yeah, I think, you know, when we were talking about inter-reader reliability, that's more about, you know, the radiologist reading our scans, or endocrinologist or thyroidologist, whoever it is that's reading the scan. Just simply me and another person could have two different ways of categorizing, even with our, you know, super strict criteria for what's going to get 1 point and 2 points and 3 points. We still have a lot of variability between people. Interestingly, and I didn't actually present this particular talk or this study, but we actually looked at our inter-reader variability a little bit closer and actually asked the same. We used 4 in this case, experienced ultrasonographers to read our same nodules 1 month apart. And amazingly, there was even intra-reader variability. And I mean, this is like, you know, these are people who are obviously wonderful at their job, are extremely experienced, and it's just humbling, right? It's just humbling to know we are human. We're going to miss things. We're going to change our mind about things. Something's going to make us say, oh, no, there, and we're going to miss it the next time. And it's really, you know, again, I will just simply say it is humbling. So I would say that, you know, if people are interested in using AI, if they're first of all, willing to be humble about their ability, but then also willing to collaborate and kind of be able to add to this, this amount of information and data. I will say that the processing of the images in order to feed them through our algorithm was very time intensive, and took a lot of work on you know, on the front end to be able to input those into the algorithm. So hopefully that becomes easier. Maybe that's something that, again, somebody with a lot more knowledge of AI out there can help, you know, hone in on how we can take a look at those CT images, ultrasound images, cytology image slides. And especially, I think most of us would be super excited to know whether or not it can accurately look at a cine loop, so that we're not just looking at a still image, because as all of us who have done ultrasound on the thyroid know, a still image is kind of nothing when it comes to a thyroid nodule. We really need to, you know, scan over it ourselves, sometimes push down on it, sometimes, you know, go back and forth over it. So I think that that's really where I want to see more data, more data, more data. And again, as the non-AI portion expert, I hope that there is somebody out there figuring that out for us, and hopefully we can collaborate in that way. So
you were mentioning that this is a very time-consuming process, and in regard to that, Dr. Mark Erkin is asking if you could speak to us about the time element and the efficiency of incorporating AI into the workflow of thyroid nodule assessment.
So I think, and this may actually be a better question for the presenter from Mass General who just presented 2 weeks ago, because they seem to actually have a clinical application. Our study was much more kind of raw, taking a look, retrospectively, not so much how can I get this into my clinical setting, whereas theirs was much more focused on how can I use this today? And so I don't have as much of experience with that. The study was 2018, so I feel like that's like not that long ago, but it's like light years when it comes to how things have progressed so quickly.
Awesome. I see another question coming from JP Brito, but JP, you're here, so since you're here, you want to take the mic?
Hi, Dr. Cottrill. Very, very wonderful presentation. Thank you. So I was very interested in the use of AutoML from Google. Can you tell us more about it? Some teams work on some institutions work with their own teams in developing these platforms. But it's interesting that you went to work, and I think it's a very interesting way to proceed with this kind of study. So can you tell us more?
I will here admit that I don't know very much about it. I was told that this is kind of what we are going to use for it, and this is the partnership that we had, and so therefore we were using it. So I wish I could tell you more about what the actual other options were, or why we went with this one versus another one. Certainly, if there is anyone who is more AI proficient, they're welcome to chime in.
No, and before last question is, one variability besides the variability that comes from which picture, how I frame it, is the variability from the machine. For instance, we have a speaker the last week, and we were talking about it, and the reason that he thought that was very difficult to come up with a standard AI platform for nodules is because we have several ultrasound machines that provide several different quality pictures, and I thought that maybe one of the outputs is that each institution will end up developing their own platforms, or at least the companies producing the ultrasound machines with selling these platforms. What are your thoughts about it? Because I imagine that might be issues in regards to working with other institutions, validating in a different machine, things like that.
Yeah, I 100% agree. And I think, so in my clinic and in the OR, I use a handheld, point of care on an iPad sort of ultrasound. And it obviously has significantly different image quality versus, a larger, more expensive, more, just top-notch machine. And it's obvious. And you can only imagine, again, the output that you're going to get from those, that neural network, that deep learning, multi-layer hoagie, is only going to be as good or as accurate or as precise as what you're feeding into it. And so I think obviously, like, the higher quality the image, the better. It would be really interesting to do a study looking at subsets of, maybe those that are taken with those point of care, on an iPad or iPhone kind of images versus those that are actually acquired with a much higher quality and resolution, and seeing if AI can kind of help us, again, being humble, to pick out the ones that are actually more suspicious. So I think it would be a good study, but yes, it's going to make it difficult for sure to to share. It is possible, I think, that again, with the volume, that difference would get a little bit muted. If we were to just kind of take all of it and put it into a system, that it would learn. That it might have the ability to
pick
to
out the difference. Yeah. Thank you.
Yep.
I was actually going to ask that same thing. When you were presenting the study that you guys performed, I had the doubt if those ultrasounds were done in-house or they came to you with those studies. I'm guessing they're in-house.
They were all in-house. Yeah, we tried to keep it to that, and we have actually just in this last year upgraded many of our machines. So it is actually something that has certainly come up as like a practical point for us in terms of future studies. we limit? Do we, put it all in? Is there a significant enough difference between the new machines that we have and the old ones? So, yeah.
Yeah, correct. I've always been an advocate and passionate about the disparities in healthcare, and specifically in thyroid cancer. And since most of thyroid cancer is treated in the community, actually, there's always that problem when you get a patient referred to you from the community, you get an ultrasound that might not be of the image that you would want it to be. And it would be amazing, like JP was mentioning a second ago, if we could all blend these studies in one same study, so we could get eliminate that interpersonal variability that exists when we read the studies, and then we have to repeat the studies to get a clearer view, making the patient spend more money, go back to the visit in the clinic. So it's a difficult process.
Yeah, it certainly is.
We're also getting a question from the audience. Very good question. They said, did you consider using the entire ultrasound image rather than a annotated, cropped out image?
Yeah, so we tried to do that at first, and honestly, the things that were that kept getting picked up were the difference in like the patient name, the date, the slight difference, for example, a female neck versus a male neck in the depth, markers on the side of the image. So those things were actually kind of like throwing everything off. Again, I'm not such a AI specialist that I'm going to know why or how, like if there was a good easy fix for that. I imagine that probably there eventually will be, but in our study we ended up just kind of having to crop it. In our very first study, we used the radiologist to kind of say, here's the picture I want you to look at, computer, and by the way, here's the focus, here's the nodule that I want you to look at. So that was the yellow box and the green box, that they kind of made these definitions. Now, it wasn't like a circle around the nodule. It was kind of like the nodule is somewhere within this bracket, the smaller bracket within the bigger picture. So it was edited, but this was also kind of our first go at it and trying to figure out how good it would be. The second study actually took that off and allowed the AI to kind of identify the nodule itself. And it did that with 100% accuracy, which was really cool to see. So I think that probably there will eventually be a platform that allows just, here's my ultrasound, I'm going to put it into the system and see what comes out the other end. But until then, and again, like I was mentioning before, it would be great if an actual loop of video or a dynamic exam could be done, that could be processed in that same way rather than just simply a still image that was pre-chosen by somebody. Camilla, I think you're muted.
I apologize. We haven't learned from the past 2 years using Zoom. In your study, did you use only one still image, or did you use like a transverse and then a sagittal view? How did you do that?
So we actually took, if you looked on our like the numbers that we had, we only had like 130, 150 nodules themselves. And then we took as many images, as many still images from those that would be representative. So some were transverse, some were sagittal. So we had multiple images of the one nodule. And so in the end, our data set, our image set ended up being somewhere over 650 images that we could use. And so we did try to keep for the learning, the kind of like input at the beginning, the learning module and the testing module, we tried to keep those actually separate nodules so that they weren't getting a different but maybe too similar picture from a nodule that they had previously seen. By they, I mean the computer, that the program had previously seen. So trying to kind of make it a little bit more stringent, but again, giving it as many pictures as possible, sometimes of the same nodule, but just a different view. As we know, again, the dynamic exam might show one part of the nodule looks mostly solid and another part looks mostly cystic and another part looks somewhere in between. And so there are different images that we could pull out from even that single nodule. So hopefully that answers.
Right. A couple of months back, it might have been almost at the beginning of the start of the series, way back when COVID hit. we had the opportunity to have Dr. Johnson Thomas from Springfield, Illinois, speaking something around these lines about the use of AI in thyroid nodules, and he introduced a term that I wasn't familiar with. He, instead of doing a black box or deep network assessment of thyroid nodules, they did a physician in loop kind of algorithm where they kind of tweaked if they disagreed with what the outcome was, to try to improve the sensitivity and specificity that came out of that study. I thought that was interesting. So in the analogy of the club sandwich, that would be like adding a little bit of sauce to that. So how you feel if we could do something like that? Do you think that there's room for improvement from what comes out of that? I have the tendency to feel like that in a similar fashion as when you do a systematic review, that what you input into the network is what you're going to get out of it. So what do you think?
Yeah, I think it would be interesting to certainly evaluate that kind of approach. For this particular, study, I think we had a very limited data set and very limited sort of final diagnoses. As I mentioned before, we were trying to look at these indeterminate nodules, only a small number of which go to surgery and give us a definitive final. And so it's hard to make those adjustments unless you truly have that kind of concrete data. And as I mentioned sort of at the beginning, especially for those nodules, it's really hard to kind of limit ourselves to only those that have final histopathology, because so many, just are not going to have it. And so we don't want to have that selection bias in the beginning. So I think as long as we're cognizant of the biases that we're bringing in and, bringing with us as we make our insertions into the plan, I think that that's, certainly something that can and should be evaluated.
Are you aware of any efforts that are being made to do something like this, but in parathyroids?
I think that there are a couple of groups. We actually are kind of looking a little bit at ultrasound specifically for parathyroid. I think there are a few groups that are looking into it. I don't know where they are on the sort of process of it, but.
Awesome. And then I've always thought about extrapolating these kind of studies into other types of concepts. For example, you were mentioning NIFT-P. Do you think there's room for us to evaluate maybe foresee NIFT-P histological result from ultrasound using AI?
That's a great question. My feeling is kind of like, if the best cytopathologists in the world can't do it, it's quite possible that AI can't do it either. Who am I to say that that they are not, just as good as it can get? Some of it really has to do with like, well, if you don't have the capsule of the nodule, available for you to look at, then you just can't do it. It's one of those things. So I think that there will be inherent limitations, but I do think, it is interesting that, up to 30% of our FNAs are indeterminate. And if we could get that down to 10% or 15%, that would be, a huge improvement, I think, in cytology. So I do think, kind of going back to that idea about community hospitals and that sort of thing, I actually personally work at both our main university hospital and also a community hospital. I split my time 50-50. And I see a difference in, the quality of reporting and the quality of diagnostic accuracy that comes out of each of those. And so it's important for me to trust my cytopathologist at the community hospital. But it would also be wonderful if there was a way to kind of augment that ability without simply saying, yeah, I'm going to need this reviewed downtown. I'm going to need this reviewed downtown. And, I always feel badly about doing it when I have it in question, but, it's a difference in one person trying to read cytopathology for every subspecialty within a hospital versus a department that has 3 people solely reading thyroid cytopathology, which is just very different,
Correct. In your study, did you have to exclude any patients based on the size? Sometimes when you're doing point of care ultrasound, the nodule might be so big that it's difficult to evaluate the whole nodule.
Yes.
Is there any of those nodules that had to be excluded because the AI wouldn't be able to
look at the whole thing? Yeah, there were a couple of like substernal nodules, and I don't know if there were any that were simply all cervical but too large to include. I think there were a couple that had substernal extension where it was too difficult to actually get quality images of it. So yes, that is the case. I don't know how many off the top of my head. It was not very many though. It maybe 4 or 5.
Great. We have a question coming in that it asks us, do you feel that ultrasound is more or less conducive to pattern recognition compared with CT or MRI imaging?
That's a good question. I mean, I think probably both are conducive to it in some way, shape, or form. Our group is actually looking right now at CT for head and neck squamous cell carcinoma to see if we can predict evidence of extranodal extension on CT scan. So I think that it does lend itself, CT does lend itself. My feeling is that likely there is something inherent about ultrasound and kind of the shades of gray basically that are there and that are available, the detail that's available. Sometimes you just see, you can see a hilum within a lymph node, whereas you can't really see that on CT scan. So there may be some amount of granularity or detail that is more accessible on ultrasound, which may lend itself better. I think that has yet to be seen, and I do think that people are doing high quality studies with CT as well.
Awesome. One last question. At the beginning of your presentation, you were mentioning how you had the NGS assessments and you had all of those different mutations. RET mutation is one of them. And was there any difference in ultrasound features or characteristics that you found in patients that had RET mutation, meaning that they were potentially medullary carcinomas versus the rest of other type of mutated?
More often than not, we're seeing actually like RET fusions in those indeterminate nodules. So RET mutations, we do see obviously a medullary, but usually the cytology is a little bit more definitive and kind of puts it into a different category. In the indeterminate nodules, we have seen a lot of RET fusions more often. I can't speak to exactly the frequency of those or sort of what the outcome is. I don't have that data in front of me. For this particular study, actually none of them had a RET mutation. I think there were 9 with BRAF mutations. There was 1 with a P10 mutation, quite a few with RAS mutations, 3, I believe, with TERT mutations. So those, it just wasn't one of the ones that was included in this particular study. It's on our panel, but it wasn't positive in any of the nodules.
Great, thank you. At this point, having no further questions from the audience, we would like to thank you so much for your time. This was a very, very interesting lecture. We hope to see you again soon in the near future, and I would like to invite the rest of the audience to join in the future coming Thyroid by MD's webinar series. Next week, we'll have 2 more board moderated by Dr. Mike Cottrill, and the case presenter is going to be Dr. Rick Payne from McGill University. So hope we can see you all there.
Awesome. Thank you all so much again.